From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello and welcome to this JAMA Cardiology podcast. I'm your host, Dr. James Udelson, Chief of Cardiology at Tufts Medical Center in Boston and an Associate Editor at JAMA Cardiology. Today, I'm joined by Dr. Sanjiv Shah. Sanjiv is the Neil Stone Endowed Professor of Medicine at Northwestern Feinberg School of Medicine, the Director of Research for the Bloom Cardiovascular Institute, the Director of Center for Deep Phenotyping and Precision Medicine in the Institute for Augmented Intelligence in Medicine, and Director of the Heart Failure with Preserved Ejection Fraction Program at Northwestern. Sanjiv is also a former Associate Editor of JAMA Cardiology. And he's going to be here today talking with me about the long-term effects of an atrial shunt device on cardiac structure and function in HFpEF based on a paper coming out in JAMA Cardiology. Sanjiv, welcome.
Thanks, Jim. It's really a pleasure to be here today.
So let's jump in the time machine a little bit and go back. What piqued your interest in this area of devices for interatrial shunting initially?
Really, it stemmed from an observation with mitral stenosis that happened over 100 years ago. René Lutenbacher from France had described in the early 1900s a case of a patient with a congenital atrial septal defect who also had rheumatic mitral stenosis, and found that basically the atrial septal defect was unloading the left atrium into the greater volume reservoir of the great veins and also the right atrium. And so there was this thought that if patients have an atrial septal defect when their left atrial pressure is high, such as in mitral stenosis, that this could decompress the left atrium. Now, what's very interesting is in that same report, Dr. Lutenbacher describes the pathologic findings in that patient and describes the fact that if the shunt is too big and goes on for too long, the patient can develop right ventricular failure and right heart failure and death. And so from the beginning, we knew that we really had to select the right patients for this therapy. They needed to have elevated left atrial pressures during exercise, but they also must have a pretty healthy right heart. Otherwise, they would not benefit from it. And so over the years, we've done a number of studies, both open label and randomized trials, where we've gotten to know a lot more about atrial shunting and where it may be most beneficial in heart failure.
Can you tell us at a high level about the phase 2 trials that set the stage for the pivotal trial?
Still to date, the only phase 2 randomized clinical trial of atrial shunt therapy completed to date is really the reduced LAP HF1 with the Corvia Medical atrial shunt device. And that study was only 44 patients, but they were randomized 1-to-1 to a atrial shunt device or sham control. And that study found that with 1 month of atrial shunting, those patients actually had lower pulmonary capillary wedge pressure during exercise compared to sham control. That was what really proved that this was a therapy that could, in fact, reduce left atrial pressures during exercise. Now, there have been a number of open label studies which have all shown that atrial shunting is safe, and at least an open label study seems to lower left atrial pressure and improve symptoms and quality of life and exercise capacity. However, in this RCT that we did, it was sort of small in size, but we did not find any improvements in KCCQ or 6-minute walk distance with that small number. And so that's what led to the pivotal trial.
Wasn't in that trial there was a hint of an outcome benefit, right, in terms of heart failure admissions?
So at 1 year, there did seem to be a suggestion that there was a reduction in heart failure events in the atrial shunt treated patients versus sham control. So that got us excited, thinking that there really may be a beneficial response, not just for lowering left atrial pressure and potentially improving exercise capacity and symptoms, but also maybe reducing heart failure events.
So then that set the stage, of course, for the pivotal trial, Reduce LAP2. And can you tell us about what you found there? And then after that, we'll talk a bit about the responder analysis.
Yeah, well, it was really quite an undertaking. It was at 89 centers across the world. And what was interesting and new about this trial was, number one, it was the largest interventional HFpEF trial to date, but also that we required exercise invasive hemodynamics. So as compared to pharmacological trials in heart failure with preserved EF, this was definitive evidence that during exercise, pulmonary capillary wedge pressure was elevated over 25 millimeters mercury. Now, what was also interesting was about a third of patients had pulmonary capillary wedge pressure less than 15 at rest, what we call exercise-induced left atrial hypertension. And this points to the importance of exercise invasive hemodynamic testing. When we started the trial, many thought that we would never be able to pull off exercise invasive hemodynamics at so many sites across the world who hadn't done it, but the trial really proved that we could do it. So we were proud of that, and we randomized 626 patients to either atrial shunt device or sham control. It was a 1-to-1 randomization, and crossover was allowed at 2 years. Now, predominantly, these patients were HFpEF with an ejection fraction greater than or equal to 50%, 93% of them, and the other 7% had an EF 40 to 50. And what we found was that based on the primary outcome, which was a hierarchical endpoint at 1 year, and at the top of that hierarchy was cardiovascular death or non-fatal ischemic stroke. The next level was heart failure events, so heart failure hospitalizations. And then the third tier was KCCQ improvement by greater than 5 or more points. And the win ratio was exactly 1, so a completely neutral trial. There wasn't any excess of cardiovascular death or stroke at 1 year. And there was no excess of heart failure events at 1 year, but it was really a neutral trial.
I remember when you presented that, after you finished came the subgroup analysis, and followed soon thereafter by a fully published manuscript, which really kind of pivoted the field, in that sense, really important. So can you describe what you and Barry Borlaug found and reported?
Yeah, so it was really interesting. When you have a neutral trial, either there's absolutely no effect and it's just neutral, or there were responders and non-responders. And in our pre-specified subgroup analyses, we found 3 groups that really differed. Interaction p-value is less than 0.05. So it seemed like men did worse. Those with a very large right atrial volume did worse, the highest tertile. And also the highest tertile of exercise pulmonary artery systolic pressure at 20 watts. So at 20 watts, if that PA systolic pressure was greater than 70, that also denoted a group that didn't respond. And so we started thinking about that, and that was the latter one, the PA systolic pressure, was the most significant interaction effect. And so we decided to do some post-hoc analyses to figure out, is that the best variable to define response, or is there another one? And through a series of investigations, we found that peak exercise pulmonary vascular resistance less than 1.74 Wood units, and the absence of a pacemaker or ICD at baseline, which comprised about 50% of the patients, those were the responders. So, it really was quite interesting because it started to make physiological sense. First of all, pacemaker ICD, we know from the study, really defines a group that has a sicker right heart. Now, we tried to exclude patients with greater than mild RV dysfunction and significant elevated pulmonary vascular resistance at rest, but we didn't really account for exercise changes. And if you think about it, if the pulmonary vascular resistance doesn't vasodilate, if the RV is sick, especially during exercise, that blood that gets shunted from left to right has nowhere to go. At least that was our hypothesis. And when we look at those 50% of the patients in the trial that were the responders, they actually did quite well. They had a win ratio of about 1.43. They improved their KCCQ by 6 points. They had 50% less heart failure events. I mean, a really blockbuster response, but of course it was all post hoc. And so we embarked on trying to figure out, okay, what other data from the trial can we examine to see if this is just a chance finding, or is there some sort of physiological reason for this result? And of course, we are validating this result in the ongoing prospective responder HF trial, which is specifically looking at this responder subgroup.
So that brings us to the topic at hand today about your current paper about the long-term echo findings. And the reason I think we thought this was so important was that this whole field really revolves around the balance between unloading the left atrium and loading the right ventricle. And it's very likely that echocardiographic findings would really give us some hints about what's going on here. So tell us, if you could, about the big picture of this current paper on the 2-year echo follow-up of reduced LAP HF2.
Yeah, well, I'm really excited to, number one, because it is the most detailed echo follow-up study of any heart failure with preserved EF trial to date. The protocol called for doing echocardiograms at baseline, 1 month, 6 months, 12 months, and 24 months. Those echocardiograms were all interpreted at the University of Pennsylvania in a central core laboratory. And it was a really detailed protocol. And we felt that we needed to do that because this was the first time we had a pivotal trial with an atrial shunt therapy. And from a safety perspective, we needed to be definitive and really follow these patients closely. And so the first thing we wanted to know was, is the shunt patent? And it is something that we tried to get on every patient. And the vast majority, we were able to get that. In fact, it was quite remarkable that 87 to 92% of the patients throughout the trial had an echo at every one of those time points. And so even though this trial coincided with the COVID pandemic, we really got good follow-up echo data. And of the evaluable echoes throughout the trial, 98% had a patent shunt. And all but 2 of those echoes in 2 different patients showed left to right shunting. And those 2 that didn't were bidirectional, but at other time points showed left to right shunting only. So it really did seem like this shunt in particular was patent, and there was consistent left to right shunting. And that's the first part of what we found in the trial.
And of course, some of that is due to the selection using exercise hemodynamics to ensure that the left atrial pressure is high enough to then translate into that longer term finding. There were so many interesting aspects. So, why don't we start with the left atrium and the left ventricle? What happened to those?
So the first thing we did was we looked at overall. We didn't get into responder, non-responder. We just said overall, what's happening over time? And one of the unique things we did is we really used every single echo data point. We used something called the mixed measure repeated analysis. And that MMRM analysis really helped us use all the data throughout the 2 years. And what we found was that the left ventricle decreased in size, left atrial minimal volume decreased in size, and left atrial emptying fraction increased in those that were treated with the shunt, really telling us that this shunt really does unload the left heart.
And it was sustained across the time period, right?
Yeah, and it was also associated with a reduction in E to E prime as well.
I think if you ask people what's the most important part of this analysis, it's the big unknown. What happens to the right ventricle?
Predictably, the right ventricle increased in size. And it was kind of interesting. The right ventricle increased by a mean of 9 milliliters, and the right atrium, same thing, 9 milliliters on average. And so that made sense to us. That is the amount of blood we would predict on average with a QPQS of about 1.2 to 1.3, that you will get a little bit of enlargement of the right-sided chambers. Now, if the right atrium and right ventricle are healthy, they can accommodate that. But if they're not, then that might be a problem. What was good to see was that there was no decrement in RV systolic function at all that we found here. So despite the mild dilation of the right heart chambers, there was no reduction in the right ventricular systolic function, and pulmonary artery systolic pressure and right atrial pressure in the entire group stayed neutral, basically no change over time.
In some ways, this is almost like someone with mild aortic regurgitation, that a healthy LV can accommodate that, and the risk of deterioration over time is quite minimal.
It's not in this particular paper, but we have now 2 and 3 year follow-up data. And we're really not seeing a bunch of right-sided heart failure. It's really not, at least in this population, we were very careful about selecting the patients. And that's not the mode of death. That's not the mode of heart failure hospitalizations as far as we can see. So it was interesting in respect to the echo. Okay, well, what's actually happening to these patients, and why are they, especially in the non-responders, what's happening to them over time?
Another really important piece of this paper was looking at the long-term effects in the responders versus non-responders. Did that concept play out over time in LVRV structure?
We basically looked to see where the responders and non-responders different. I'll just start by saying that last year at the ESC heart failure meeting, we showed that the 2-year outcomes were pretty dramatic. In the responder group, there were 50% reduced heart failure events, and the curves continued to divide and diverge. But in the non-responders, there was a 2.2-fold increased risk, so a 200% increased risk of heart failure events. So something was going on. And so what we found was where they diverged the most was on the relative RV enlargement compared to decrease in LV size. So first of all, the RV increased to a much greater amount in the non-responders, RV and RA size. The RV-LV ratio increased by 0.2 in the non-responders and 0.07 in the responders. So there's less right heart enlargement. The other thing that was interesting was that you would expect if the RV dilates through the Starling law that there would be increased or improved RV systolic function, and that's exactly what we saw in the responders. We didn't see that in the non-responders. And so both the responders and non-responders seem to decrease the left heart size, but the responders don't have as outsized a response in the right side. Now, the other thing that was interesting was that the non-responders, the right atrial pressure went up, cardiac output didn't go up, it fell a little bit. So I'll try to break it down in real simple terms because there's a lot of different echo parameters here that we analyzed. And it comes down to this. In the responders, the blood shunts from the left atrium to the right atrium, goes to the right heart, but then is able to get through the pulmonary vasculature and back to the left heart and out to the body. So that blood is transferred. And the other thing that we saw in the responder group was that the transmitral A wave went up. That's a sign that the left atrium is functioning better, it's contracting better. Blood is actually going through to the left heart. And this is because the pulmonary vasculature is healthier, it can vasodilate during exercise, the right atrium and right ventricle are healthier. Now let's look at the non-responders. In the non-responders, the blood goes from the left atrium to the right atrium and right ventricle and just sits there. It just sits there. It never actually gets back to the left heart. So cardiac output goes down, the right side is overloaded, and patients do worse. That seems to be enough to cause these excess in heart failure events and the lack of improvement in KCCQ or health status, quality of life and symptoms. And it was very, very clear using this echo analysis that this physiology really supports this responder phenotype and I think explains what was going on in the divergent effects in responders and non-responders.
That's really why we thought this paper was so important. I mean, it's explaining a lot about which patients might respond and might not. And, as you know, I mean, you are continuing with another pivotal trial. There are others going on, and one soon to be presented at the ACC, where exercise hemodynamics were really not done to select. There wasn't the exercise PVR selection. So, we'll have soon in the next 2 to 3 years, an enormous amount of information. But I think the studies that you've done have really influenced the field in a huge way. Any predictions about the future for this therapy or the different approaches?
Well, there's at least 8 companies out there developing these devices or procedures with no device, different aspects, some intra-atrial shunt. There's one that's left atrium to coronary sinus shunting. So I hope that we find a group and a device or procedure that works here. I think that there are some really promising results from a lot of these studies. We'll see what the RELIEVE-HF study reports out at ACC coming up, as you say. But it does seem like there are some patients who do benefit and don't have any of the long-term adverse consequences. I can tell you from my patients enrolled in the trial now that I'm unblinded, it's quite remarkable how some patients have responded really beneficially to this therapy. So I'm excited for what the future holds. I think we need to continue to do rigorous trials, and I think we're learning about physiology of HFpEF.
It has really brought hemodynamics back to the fore, and I agree with what you said before, to show that you can do exercise hemodynamics in 700 patients around the world. That in and of itself is an advance that will help patients. Well, thank you, Sanjiv. A really important paper. You've done a lot to advance this field since they first came to you in 2009. More to come in the next few years. So thank you so much for doing this today.
It's my pleasure, Jim.
Thanks to everyone for listening. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks so much for listening.